My presentation is simple at your practice level. The outline is what is acne, what are the characteristics of classical acne, or what is commonly referred to as acne vulgaris. Of course, if there is acne vulgaris, is there non-classical acne? Probably there is. Just a brush through about the pathophysiology of acne, classification, assessment, grading, and of course there are very many other issues that are not well understood in acne, which we also just go through. For all intents and purposes, when one talks about acne without further qualification, they are probably talking about acne vulgaris, which is simply put as clinically they present as rashes, pimples, bumps on the face and upper trunk, often, not always, often starting during adolescence. People may refer it as just acne, as I said. Others will just call it acne vulgaris. Others will call it classical acne. Others will just say this is adolescent acne, adolescent pimples. All these are terms that are used to describe that. Sometimes you find terms like acne fulminans, which we'll go into it further on, or acne excoriae, which are just a further qualification of acne, usually acne vulgaris, which either is very bad to the extent that they call it fulminans, acne excoriae, which is not really acne, but it presents in the right, among the right subjects, but the cause is not the same, is of different pathophysiological origin. And therefore, to be able to understand acne variants and classification, we need just to quickly review what is classical acne. Classical acne is actually chronic, is relapsing skin condition, which presents with rashes, pimples, papules, erythema, pustules, nodules, pseudocysts, and abscesses, and so quite often scars and keloids, and with pigmentary changes. We say it's chronic, just to be clear that people who come to see us for this condition often get frustrated, and they will even tell you, you are giving me something I was given by somebody else, but it didn't work. So you have to spend a little bit more time to tell them if they are looking for somebody to clear the acne, they may not get there. The lesions usually occur on the face, the chin, the forehead, sometimes on the shoulders, the upper back, upper chest, sternal area, that is in the chest, often in adolescents and young adults. The above presentations can occur singly, that is, you only have papules or nodules, but often in combination, so that you'll see it in different stages. The type and severity of the acne in an individual can also vary within the individual, whether they are on treatment or not. So it implies that apart from the treatment, there is something else that is modifying the acne. Either, we may not know what, but either the hormonal changes, the diet, the climate, all those things. The skincare issues, all those influence acne. The overall morbidity, actually, when you look at all diseases causing morbidity, acne is rated as the 8th commonest disease worldwide. It affects 80 to 90% of adolescents at one point in time. They may not continue with it, but they will say they had it at one time. When you come to dermatology, acne is always a code to eczema as the commonest skin disease. For those people who are looking after adolescents and young adults, it may be the commonest skin condition you'll see. And therefore, that is how the term acne vulgaris came about, because vulgaris means common acne. That are different from what is generally accepted as features of acne vulgaris. The differences may be coming from several aspects. The morphology of the lesions may be different. The areas of the skin affected may be different. The subject categories also may be different. Predisposing factors may be different. Cause of disease when you treat it may be different. Prognosis may be different. There may be other comorbid conditions which makes it, even if it presents as acne, you may say this is a variant of acne. It's not really the vulgaris we know. Response to therapy may also be different. And if the etiology is known or it has been determined, you may also see it's different. The cascade I have there looks at what is seen to be somebody presenting with rashes, which I call acneiform lashes. It could be acne vulgaris, it could be something else. So if somebody presents like that, either they could be having, as I said, acne vulgaris, or they may also have the non-classical acne. Whether they are acne vulgaris or the non-classical acne will be determined further on as one proceeds. If it's acne vulgaris is usually divided into two broad categories, either the inflammatory or the non-inflammatory. The non-inflammatory tends to be the less severe forms of acne, and the characteristic finding in the non-inflammatory are the comedones. So you have the comedonal, also what is called the comedonal acne, which may be closed or open. If they are open, when you look, you'll see the dark spots on the apex of the papules. The non-comedonal acne is a bit severe form of acne, and it may also be, it is non-inflammatory. It presents as a non-inflammatory papule. All these grades of acne is the less severe forms of acne. The inflammatory arm of acne has papules, pustules, nodules, pseudocysts, scars, and keloids. Most of the people we see in our clinics will probably belong to the inflammatory category, because that is where they are coming anyway. If it was something simple, they would have managed themselves at home, or they would have gotten satisfaction from their local primary health clinicians. The four factors acting at the pilosebaceous unit which explain the development of acne, primordial lesion has been covered by the previous presenter. The epidermal proliferation, the excess sebum, the overgrowing of the Cutibacterium acnes, and the inflammation. The three lead to inflammation, but it has also been noted for people who are studying cell biology that quite often the inflammation may start even before the other. So the question now is, what causes the inflammation? What caused the inflammation? When the inflammation occurs, of course, there are now all the other activities do occur. The CD4 lymphocytes, the macrophages, the release of cytokines and inflammatory, the whole set of inflammatory cascade sets in. That is the pilosebaceous unit, which is the theater of activity in acne. The sebaceous gland itself, the follicle, the sebum, the skin surface, and the hair. Acne vulgaris can be further subclassified into categories like nodulocystic acne, acne coagulata, acne fulminans. You may have a clinical entity of acne in pregnancy. There is also the subclass of late onset acne, pre-adolescent acne. That is acne before adolescence. It also occurs. Quite a number of times you will find somebody coming to you with skin facial lesions, and you tell them it's acne, and then they ask you, at my age, that's a very common question, that somebody doubts that they can get acne at their 40s or 50s. The photograph in front of us is of something that looks acne, but it is not acne, it's oil acne, which could be confused with the vulgaris, but it is not acne vulgaris. For acne vulgaris, there is usually a grading system to say how severe it is so that it can guide you in how aggressive to be in the management. As at now, there is no universally agreed grading system. Every center seems to use its own system because I think most of the systems are not reproducible, so that somebody seen in this center will be graded different from another center. Also, computer programs have been developed whereby you can take a picture of acne and then the computer will run it through and they will tell you this is grade 3 or grade whatever. So it will classify them for you, but they are not widely accepted. The systems use a count method that they look at what we said about the comedones, about the papules, about the pustules, the inflammation, and then they are able to count how many comedones were there, how many inflammatory papules are there, how many nodules, blah, 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 and then come up with a score, and therefore grades the acne that way. Of course, it's a very tedious process for clinical use. And of course, when you use like the computer system, they ignore the level of disablement, that how much does this acne affect the individual, the anatomical sites, and of course the scarring. Simply put, and this is what most of us do, and I think I'm in agreement with most, what I say is agreeable to most of you. Quite often we will grade acne in just saying it's mild acne, comedonal inflamed acne, papular acne, and so on, and cystic and nodulocystic acne. This is a bad case of nodulocystic acne which has scarred. I think somebody will discuss about, even if not to any detail, about the management of acne. But I would just like to go through very quickly about the difficulties of management and special population groups, because quite often you'll come across somebody with acne, but they are not in the categories we have gone through. the pre-adolescence acne. This is acne in 7, 8, 9, 10-year-olds. And then you wonder, should I use this? Should I use not? Things like doxycycline are contraindicated in that age. But I think there are some centers that are using them in children as young as 8 years. Isotretinoin has also been used in some centers, but of course, it's not, if you look at the approvals, there are no approvals for that age. Women in childbearing age, they will need, you need to look at spironolactone and issues of addressing hyperadrenalism states. Pregnant women, of course, acne gets better with pregnancy. So you may, the advice is to use very mild topical treatments until there are very serious issues that you want to address through aggressive management. Comorbidities that may occur in acne. Some diseases may give you, I mean, people with other diseases may also develop acne. They are not exempt from developing acne. And therefore, acne may be one of the comorbid diseases you are managing in an individual. Or sometimes acne may be a disease within the comorbid. And therefore, these are special categories which you require to look and rethink about how you go about managing. The clinical subcategories of acne, some are not really subcategories. They are given a name simply to indicate either a poor outcome or a different presentation. Like when you say nodulocystic acne is just a severe form of acne vulgaris. When you say about acne conglobata, is a severe form of nodulocystic acne with interconnecting fistulae and sinuses. Acne fulminans is a type of acne vulgaris whereby you are treating and they seem to get worse because of an outpouring of inflammatory agents. Late onset acne is not common, but it can occur. That is, acne vulgaris may occur in the late 20s and 30s. But if you see somebody in the 40s and 50s developing acne, you require to think about other diseases that may give you acne-like lesions. Carbohydrate metabolism, I think it was mentioned by my presenter, is something to look at, and insulin resistance. Pre-adolescent acne, that is acne in 7, 8-year-olds. It may be acne, but you also require to remember that it may signal hyperandrogenism, that you should investigate them for that. Acne excoriae is not really an acne. This is an acne-like lesion that appear in a category of people who are overconscious, psychologically insecure individuals who pick at every spot they have on their face. The age may be the right one because these are the adolescents. That is when they start knowing who they are. And therefore, any small thing, they may try to mechanically repair it or remove it, and therefore get acne excoriae. An important category to look at is neonatal acne. Neonatal acne, this is acne-like lesions that occur within the very first few months, actually few weeks of life. many of those presentations, they look clinically similar, but etiologically, they are very different. They are different and unrelated. What is known about them is many of them do not have comedones, but they do present with sebaceous hyperplasia. Bacteria and yeast infection overgrowth is very common, especially in our settings whereby birth processes are very difficult or prolonged, in which case when the baby comes, you do see some pustules or papules. Miliaria is another condition, is not acne. But the good thing with the neonatal, what looks to be neonatal acne is that most of them are self-limiting, whether you treat them or not, and they're also short-lived. There are also other variants of acne, which are non-classical acne, like oil acne. I think we have gone through it. Cloacne, acne in endocrinopathies, that is in endocrine diseases, like polycystic ovarian syndrome, growth hormone disorders, insulin disorders, acne comorbid conditions, friction wax, acne, clothing occlusion, something that was discussed in the morning. I mean, we are now seeing mask acne. And therefore, there are many things that can be studied in acne. And with that very quick runoff, I beg to sit down. Thank you.